Good evening to all. We are going to present a case of carcinoma breast. My patient is a 40 years old female, daily wager by occupation, belonging to low socioeconomic status, presented with the chief complaints of lump in the right breast for 4 months. The patient noticed a lump in her right breast incidentally 4 months back, which was insidious in onset, initially around 2 cm in size, gradually progressed to attain the present size. It is associated with a dull aching pain, which was non-cyclical, not radiating, and relieved spontaneously after some time. No history of nipple discharge and nipple retraction, no history of skin changes, no history of similar swelling in the opposite breast or axilla, no history of trauma, no history of fever, no history of loss of weight and appetite, no history of backache, no history of breathlessness, cough, hemoptysis, no history of abdominal distension or jaundice, no history of headache, vomiting, seizures.
ஒரே ஒரு லைனாகவே கேட்டுறது. How did you ask the history of skin changes in the patient?
Any ulcer, eczema?
Any ulcer is different. You already said there is no ulcer. Then you said you are asked for skin changes.
History of any redness or ulcers? Redness.
Redness. Why? So personally you will see that. Okay.
Usually inspectory finding don't change into the history. Have something for inspection. And you have written jaundice. Have you seen any secondary liver with jaundice?
Jaundice is the commonest way that.
No.
Then? Don't say it.
Okay.
Oh, you headache and vomiting? What is your?
Brain metastasis.
Brain?
Seizures.
Where it goes? In the brain, which part is involved?
Hippocampus.
Hippocampus. So will it produce the vomiting? It produces with a space occupying lesion. So it is going to produce a vomiting. So why you get in the hippocampus mainly? Amygdala, hippocampus. It's all estrogen sensitive or. Okay.
Past history, she underwent a treatment for primary infertility 5 years back with oral medications, and exact details are not available. She was hospitalized and treated for an episode of wheezing 10 years back, and the treatment details are not available. Not a known case of type 2 diabetes mellitus, systemic hypertension, coronary artery disease, and bronchial asthma. No history of similar illness in the past. No history of surgeries in the past. No history of radiation exposure.
See, in what way that your history of infertility treatment? It is significant for this patient?
Is nulliparous.
Nulliparous, okay. What they'll give for infertility? Oral drugs?
Oral drugs usually for PCOS, clomiphene citrate, metformin.
Usually
letrozole,
hormonal tablet along with to
oral condom.
prime the uterus for
Estrogen also.
implantation, everything. So mostly oral estrogen, progesterone combination, hormonal therapy, everything will be there. And what was the treatment for wheezing 10 years back? Is it relevant to your history?
No. 10 years back,
Only
she had
episode
only
of
one
wheezing.
episode of wheezing.
Oh,
Which is irrelevant.
she is able to remember that, but
Yes.
not.
You ask for any hospitalization.
Hospitalization.
So why you are particularly worried about that nulliparity?
Increased.
More number of menstrual cycles will be there.
Keep it close.
She will be exposed to more estrogens.
That is unusually that word is again repeated. Just 9 months of pregnancy and 9 months, that nullifies the total number of estrogen cycles.
Total number of cycles she will be
Yes,
more.
total number of cycles, 9 months means 9 cycle.
9 cycle குறஞ்சா போதுமா?
Kuranja, then
Malignancy இல்லன்னு.
so we will all induce menopause little earlier. So number of 9 cycle will be less, so they cause. Any other structural change, anatomical change will take place in the uterus, breast.
Breast.
Full term pregnancy breast will have a less sensitive to the estrogens.
What will happen to the duct structures? How the duct will be developed in pregnancy and lactation?
Different types of ducts, no? Type 1, type 2, type 3. What is that pattern? Why estrogen is during pregnancy it is less sensitive? It has another job of preparing milk continuously during the lactation especially. So it cannot do for all the other job. And also the patient will take lot of good foods when he is whenever they feed. Full lot of diet modifications, all that will be very good for the people. So pregnancy is always good, but you should know why and lactation is not, why the nulliparous is more prone.
Menstrual history, she attained menarche at 15 years of age. She has regular cycles 3/28. Last menstrual period was 19-10-24. Marital history, married at 32 years of age, nulliparous. Personal history, not habituated to alcohol or smoking. Mixed diet, normal bowel and bladder habits, normal sleep pattern, normal appetite.
Why are you asking for normal bowel and bladder habits?
It has any effect or no effect?
No.
No effect. Madam is doing PhD on that. Gut microbiome and your malignancy. Is it your normal bowel and bladder habits plays a role in the production pattern and development of the malignancy? It plays a major role.
Major.
Even the diet what you are going to take also decide on the how your bowel habit. When you are going to take more fruits, when you are going to have a more orange fruits, you are going to have your bowel habits is normal, and that is one of the protective factor for that patient. And with a lot of history, what you say, what are the factors, risk factors for this patient?
Nulliparous.
Nulliparous.
Treatment for infertility.
There is some hormonal therapy. Okay.
Maybe.
Anything else? What are the risk factors for this lady? Being a woman itself is a risk factor.
Respect of female.
Okay. Then
What is her age?
40 years.
40 years. No other risk factors. So suppose he is a continuous wheezing, if she is taking steroids, is it has any role?
Where the estrogen is developed? How the estrogen is produced?
Ovaries.
Do you have any estrogen production in male?
Adipose tissue.
Adipose tissue.
So have a steroids conversion into the estrogens.
So wheezing and your treatment, somebody, because most these people will be more prone to take the steroids many times. You go to the
Family history, no history of similar illness in the family, no history of any malignancies in the family.
Don't give a blanket statements. What is the similar? There is no nulliparous woman in that family.
Yes.
Breast lump.
That's
Any
also
lump
history, no?
or a breast cancer.
Breast lump.
Huh?
History of breast lump.
So in the provisional history, in the history you are making a system, which system is affected, which that. So you have to go the family history particular to that. Don't just generally put like a hydrocele will say no other similar complaint in the family. So all woman is going to have hydrocele. So what problems you are going to discuss that we must see.
You can directly say patient doesn't give any family history of cancer breast. And other malignancy also you can specify what are the other malignancy you can ask for. As a PG it will be better.
Summary, my patient is a 40 years old, premenopausal nulliparous woman without comorbidities, presented with a painful progressive lump for the past 4 months. She underwent treatment for primary
Why
Is the lump
painful?
painful?
Yes, dull
Yes,
aching pain.
dull aching pain.
What is the reason for pain? What is the size of the lump?
4 centimeters.
4 centimeters.
4 centimeter mass, painful. What is Tietz syndrome?
Costochondritis.
Tietz. So is it a costochondritis?
When will a malignant lump produce pain?
It's in the capsule of the tumor. If it invades
Sudden
the
enlargement.
Capsule of the tumor.
In,
Breast carcinoma
Breast
encapsulated,
cancer.
well encapsulated.
have you ever seen a capsule in
lump,
a breast lump? Have you ever seen a capsule in malignant lump?
Sir is asking, what is the cause for pain in this CA breast?
if it invades skin,
So classically, to start with, it is painless lump. Progresses, they may develop pain. So how do they develop pain?
Due to skin involvement, neural involvement, or
if it invades
hemorrhage into the large mass, causes necrosis, secondary infections,
In your case, any such things are there?
skin fixation,
fixity is there.
Skin fixity.
Painful அப்படின்றது
See, when you say painful, you point more towards inflammatory swelling. Okay, you should not commit it outrightly. Patient will tell you. If you ask, do you have pain? They'll tell you, I have pain. So, yeah, at the end of the examination, you should analyze what to tell and what not to tell. You are a postgraduate. Okay, so when you commit something, you should be able to explain.
Okay, sir.
Okay.
on examination after obtaining informed consent,
you go to local examination.
on inspection, patient was exposed up to her waist. On sitting position with hands by the side, both breast appears symmetrical. Both nipples are at same level, not retracted. Areola normal. No edema, ulcers, nodule over the breast, over the skin. On elevating arms above the head, puckering noted in the right breast at 5 o'clock position in the lower inner quadrant. Inframammary region normal. On leaning forward, both breast falls forward.
Are you able to see the inframammary region or raising the head above the?
Not able to appreciate fully.
Then why are you telling that?
You are saying inframammary region is normal.
படத்தை போட்டுட்டு வர சொல்லுவாங்க.
On supine position, a single irregular lump of size 4 x 3 cm seen at 5 o'clock position in the right breast, lower inner quadrant. Puckering present in the overlying skin. Left breast appears normal. No fullness noted in both axial and supraclavicular fossa.
Is upper, this quadrant is a common quadrant?
No, sir. On palpation, there is no local rise in temperature. Non-tender, a single lump of size 4 x 3 cm with irregular surface and ill-defined margin involving lower inner quadrant of the breast. Is hard in consistency, no nipple retraction. Lump moves along with the breast tissue. Skin over the lump not mobile. No muscle fixity or chest wall fixity.
You are telling this is tethering or skin fixity?
Skin fixity.
Tethering.
Skin fixity.
Tethering. We are examining tethering, sir.
No, what you are demonstrating is tethering, but you are saying it is skin fixity.
Skin fixity also.
Skin is not mobile over the lump.
Skin is
In
mobile
case
or
of-
skin is not pinchable?
Not pinchable.
Pinchable.
Sliding over the skin is not possible.
Possible.
No palpable nodes in the right axilla. Supraclavicular fossa, no palpable lymph nodes. Right upper limb normal. Left breast and axilla normal. Percussion resonant node over the parasternal region. Other system examination, CVS S1 and S2 head. RS bilateral air entry normal.
What happened to the opposite breast?
Left breast. Left breast and axilla normal.
We should remember that this is right side and.
Per abdomen soft, no organomegaly. Per vaginal examination, fornix is free. Digital rectal examination, no palpable nodules. Fecal staining present. Spine and cranium normal.
Per vaginal and per rectal examination.
Per rectal examination to look for any nodules in the anterior wall.
Nodule in the?
Plummer shelf recto-vaginal pouch of Douglas.
So you are expecting some transcelomic spread. Deposits in pouch of Douglas. Okay. That is one thing. Another thing is? Is there anything that, other than your PUD deposit, that can happen in the pelvis?
Any tumor?
Krukenberg's tumor.
So she is more of 40 years old.
40 years. Premenopause.
What is a Krukenberg tumor?
It is a solid tumors of ovary occurs in case of metastatic.
Sorry, tumor of
Solid.
ovary.
Solid metastatic.
Solid metastatic disease of
That means the consistency will be solid.
Why? Why it is solid? Why not cystic?
Surface smooth or irregular.
How do they develop Krukenberg tumor? That's what? How? Okay.
Gastric carcinoma is transcelomic. What do you mean by transcelom?
Across cavity. Okay. Drop mits from the primary through the peritoneal cavity over the ovary. How do they develop? So essentially, previously it was thought Krukenberg tumor is a premenopausal condition. Okay. So the follicles rupture and there will be raw area, and the drop mits gets into the parenchyma of the ovary. So that grows and produces a Krukenberg tumor. So essentially it is a solid tumor. Predominantly it is bilateral also. Okay. So you look for POD deposit and Krukenberg tumor. What did you examine in spine? Then?
How did you examine? So from where top to down you will come or side to side you go?
Top to down.
So what you will see? Or what you will feel? Contraction of the paraspinal.
It is exactly the paraspinal, or you palpate over the spine? Why paraspinal?
Transverse.
Which part will be involved?
Transverse.
So particular, where is it? So what do you look for? Tenderness? Swelling? You get a swelling?
எதுக்கு பாப்பீங்கன்னு கேட்காங்கப்பா. டெண்டனஸ் பாப்பீங்களா, ஸ்வெல்லிங் பாப்பீங்களா?
Tenderness.
Can you get a gibbous?
Which is the common site of spinal metastasis?
Lumbar.
Why?
Keep the mic close. Wow, that's going on to YouTube.
Okay, why not in dorsal spine or cervical spine?
So what? What do you mean by vertical plexus? Internal vertebral plexus.
Both internal and external.
Let me change this mic.
மைக் சவுண்ட்.
valvulus venous system of the vertebra, sir. There are internal and external and basivertebral systems. 3 systems are there.
So vertical plexus is prevertebral, postvertebral, intervertebral.
Both.
Both. So from where to where?
From the base of skull to sacrum.
So from where you get drainage?
Posterior intercostal vein.
How many intercostal veins?
12.
All drains primarily to the vertical plexus.
Because
2 to 6.
2 to 6. first two intercostal veins drains where? It is superior intercostal vein. Supreme intercostal vein also. Okay. What is SIGA system of vein?
Venous system is in the paraspinal region.
Still you are not answered that question, that why it is in lumbar, not in thoracic. Any role of gravity? So what kind of lesion it will produce?
Osteolytic lesion.
Mostly
Mostly
Only osteolytic.
Mostly osteoclastic. Can cause osteoplastic.
there will be more osteoclastic activity in osteolysis.
More osteoclastic. Which carcinoma? Breast. So you said osteolytic? Okay, go ahead.
Diagnosed is a carcinoma right breast in a premenopausal woman of stage 2A.
Talk louder.
Stage 2A, T2 N0M.
You said skin is involved.
Yes, sir.
Now suddenly you are saying T2?
There is only skin fixity, sir. There is only skin fixity, sir.
No, when we asked whether are you checking for a tethering, you said no. Is it?
Any type of skin fixity, it will add on to the. No.
In AJCC 8th edition, only ulcer, edema and nodule will be
No,
skin involvement.
Is a tethering will produce skin fixation, and that will.
Tethering and puckering is not included. But skin fixity?
Fixity nodule.
That is what you are saying. The sliding of the skin over. You are not able to slide the skin over.
Not able.
But what is the reason? What is the reason why it is not able to slide the skin?
Extensive involvement of Ashley Cooper ligaments.
What is the difference between purdy orange and Ashley Cooper's involvement?
In purdy orange, there will be extravasation of tumor cells within the subdermal, in the skin.
Skin.
But in Ashley Cooper, there won't be extravasation of tumor cells.
Is it the fixity is due to Ashley Cooper's ligament?
If the it is like progression, sir. At first, there will be only dimpling if single Ashley Cooper, and more than once it will be puckering and tethering followed by skin.
If what will happen to the if there is a purdy orange, whether it will be a skin is fixed or not?
May not be fixed.
In this purdy orange, skin will not be fixed.
It will be
Unless you are proving that tethering is a particularly, it is pushing that mass you are going to produce. That is a different sign, tethering sign. When you are rolling the skin over the surface, if it is not possible, that always put you more prone for a malignancy. There is a teaching saying the skin tethering is not a feature, but skin fixation when you use the word. And invariably it is due to the either your purdy orange appearance, your ulceration which is going to happen. That is what is going to cause the skin fixation. That is why it is not the word pinchability to use, roll over the skin. In a tethering, the skin surface, it is because it is does not comes up to the epidermis. The Cooper's ligament just joins comes to the base of the epidermis layer only. So there we don't say it is a skin involvement. Purdy orange. So in the purdy orange, will you get a skin fixation? You can't slide over the skin. Definitely in the purdy orange, if you can slide over the skin, it is not a subcutaneous edema. It is a interhair follicle edema. It will not be. Skin alone will not be. But subcutaneous is a hair follicle. So interhair follicle will not be. So see, the Tata Mammal groups not using that word. But what is now, if you say clinically skin fixation, it is better to put it as positive. Throughout the other reason. Okay.
skin fixity.
You should have used skin is not pinched. That would have been a better terminology.
Not pinch.
When you
say only tethering is positive without saying that the skin is fixed or not, then it is were justified. But fixity is a term, different term. Yeah.
Skin fixity will upstage this tumor.
It will
No, it is purely orange nodules, ulceration or erythema that categorizes into stage T4B. But what sir is telling is, when there is purely orange, there will be skin fixity. That's what he is telling.
I'm not saying this case when you are saying this tethering that. But when what you mean by skin fixity, indirect terminology. So tethering, if you use the word just tethering, that is a different meaning. But you said it is a painful because of the skin infiltration. It is a painful. Tethering will not push the pain. And suddenly you are coming and saying it is skin is not involved. Okay. So you are very positive man and want to put that low down T2. Oh. So how you are going to proceed?
Radiological evaluations. 2+ completed the clinical examination, go for the radiological evaluation. Sonomammograms.
Louder. What do you
mean by sonomammogram?
Mammogram will be combined with the ultrasound breast by the same radiologist, so it will be easier for a correlation between the mammographic and ultrasound findings.
Whenever they are doing a mammogram, they will always correlate with the ultrasonogram only.
Of both breast and axilla.
Axilla. Mammogram of both the breast.
What view you take? What is mammogram? Low voltage, high amperage, What is linear accelerator? Is it an X-ray or not? Is it X-ray? The high voltage X-ray, to the 10 to the power of 6, the high voltage X-ray, when the beam of electrons hit on the head, the high voltage X-ray is also linear accelerator. So both these are also derivatives of the X-rays, not the radiation rays. So what is broad?
Breast imaging and data, reporting and data system.
So what are they will report? Your patient?
Virus 4A.
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 So what are the features?
There will be suspicion of malignancy, sir. Architectural distortions will be there, sir. A mass with speckled calcifications will be there, sir. Clustered.
So why you are using the word speckled calcification? You have a speckled mass or a speckled calcification?
Speckled calcification.
Speculated. What is speckled means?
Microcalcification.
Microcalcification.
Clustered microcalcification.
No, what will be there in the mass? What will be the structure you see?
Irregular architectural distortion.
Architectural distortion.
Sir is asking, how will you see the mass in the mammogram? What are the features of the mass will be in the mammogram if it is malignancy?
What will be the density?
Increase the density.
Margins. Calcification. What kind of calcification? What do you mean microcalcification?
Less than 0.1 mm.
0.1 mm. Length, breadth, which is that 0.1 mm? 0.1 mm circular.
Maximum dimension.
Huh? So any directions. What are the shape of the microcalcification?
Linear branching.
So all will have only 0.1 millimeter. So what is that 0.1, 0.2? Is the width or the length? What is radial scar?
It's a pre-malignant lesion.
No, we are talking about mammogram. What else looks like in the mammogram in a radial scar? What is mammogram scar? What is sclerosing? The linear calcification with central lucent area. That the calcification will not be there. So radial scar, sclerosing. And always you must do a biopsy when you do that. So mammogram you need to read a lot. What are the findings? What is microcalcification? What are the shapes you are going to get? And what is microcalcification? What type of calcification it is?
Dystrophic.
What is a dystrophic calcification? What are the other calcifications you know?
Metastatic.
Metastatic. Anything else? Okay. So what is the hidden area of the mammogram? You take a mammogram, what is the area which you can't see? Retroareal area. So what are the views you take? Suppose you are asked to take only one view. What view you will take?
Mediolateral.
Mediolateral. What is Cleopatra view?
Cranial caudal. A specialized form of craniocaudal view.
What is the specialization form? What is digital mammography?
We can adjust the intensity to see in dense breast in young women and all. We can use digital mammography. We can adjust with the system.
Adjust with?
Instead of using the
Films.
films, we are using screen.
Nowadays you are, instead of using the films, you are using a digital. No? How many directions you take the picture? So which is moving there? So your hospital has a digital mammogram. That means you are not going there and seeing that how they are taking a digital mammogram. Examination is mainly, especially in your institution, particular mission is there. And if the question is asked on that and if you are not looking at that mission, that is not considered as good. See, a breast is mostly what you are going to do in the, what you are doing in the practically there. Okay. Go ahead. What else?
Followed by corneal biopsy of
Keep the mic.
corneal biopsy of the
Change that.
lesion.
So you are done that. Will you go for any MRI and any findings?
MRI is not routinely indicated.
Why?
Triple assessment with mammogram itself can diagnose CA breast.
Is that is the only reason, or is there is any reason that you are not recommended to do MRI? Huh? Costlier. False positive, will it be there? There is a lot of false positive cases report, because more and more that when they report as a multicentricity, you will not go into the do the breast conservative surgery. So the incidence of false reporting with the multicentricity is very high with the MRI. So what are the indications especially for MRI?
Multicentric and multifocal tumors.
Multicentric and multifocal tumor. So if I know that it is a multicentric tumor, why should I do an MRI?
Family history.
Family history.
Family history. Breast implants.
Breast implants.
Axillary disease without breast primary.
You have a node, there is no nothing there. To differentiate surgical scar and, or when you have the BRCA1 or BRCA2 is all that positive, then you can go for an MRI. So what is the precautions you take to do the MRI?
To do with the breast coil.
Breast coil. So what do you get in a malignancy? What pattern of enhancements you get there?
Rapid wash in and wash
Rapid
out.
uptake and rapid
wash
wash out will be seen then. Okay. So any other investigation you do? PET?
Not routinely indicated, sir, except in case of if the patient has any metastatic symptoms, we have to do PET.
Metastatic symptoms.
Symptoms of metastasis.
Okay. All that is coming for a metastatic workup. Is that we are not going to talk. Is the diagnosis confirmation?
Corneal biopsy.
What size needle?
14 gauge.
14 gauge needle you are going to.
Why not FNAC?
Core needle is more sensitive than, and we can get a tissue sample of invasiveness.
Do you still need a immunohistochemistry in early breast cancer?
Early breast not. Post-op.
So can you do the immunocytochemistry? Is it possible to do immunocyto? All that investigation what you are doing on immunohistochemistry can be done using a cell itself. Immunocytochemistry can be also do that same test. And when you need that your tumor markers, prior to surgery or post-op surgery?
Prior to surgery.
Why?
The patient has triple negative breast cancer. Even in case of early breast cancer, we have to give neoadjuvant treatment.
So neoadjuvant therapy means hormonal therapy.
Trust.
Hormonal therapy you are going to give.
Triple negative.
Triple negative. No, what you give? What neoadjuvant you will give for a triple presentation?
Triple negative, no, specific what chemotherapy agent will you use? Or you will use a hormonal therapy?
Systemic therapy, hormonal therapy.
Triple negative. Already you are saying triple negative patient. Neoadjuvant you are not going to use a hormonal therapy. Anyway, that is depending upon not your this. So is it not enough you get the post-operative the specimen you send and get a ERPR?
No, you are correct. If it is triple negative, it is needed. You will do a. If even it is early breast carcinoma, you will do a neoadjuvant chemotherapy. What the specific chemotherapeutic agent you will use for the triple negative? This usually carboplatin or platinum based chemotherapy should be used for neoadjuvant, not a hormone.
Taxol, adriamycin and carboplatin. So whenever you encounter triple negative or basal like tumors, platin should be exposed. You should expose the patient to platin. Okay.
So when previously we thought that after surgery you can send for ERPR, but now what that is, if you give a neoadjuvant, if there is a complete responders, there may not be a mass. You may not be able to exactly predict. So prior operatively you must do a ERPR status to get it. When you say HER2 positive, what test you will do to see HER2 positive?
Immunohistochemistry.
So in immunohistochemistry, when will you say triple positive?
If it is 1 plus.
More than
1 plus
More than more.
is positive.
2 plus.
2 plus.
2 plus is positive. 2 plus is equivocal. So what you will do when it is equivocal?
Fish.
Go for the fish. You will going to do that. So HER2 positive. What percentage of people will be normally HER2 positive? Nearly 20% of the people. Why you want to know about HER2 positive?
Targeted therapy can be done. For targeted therapy.
Targeted therapy. What targeted therapy? Transmab. How long?
For 1 year.
1 year. Daily, weekly, monthly. Suppose the patient has a brain secondaries.
Radiotherapy.
Still you can give, this is HER2 positive. Any specific drug you can use? Any drug which crosses the blood-brain barrier? Lepatinib. So now pembrolizumab and trastuzumab is combinedly given, or you can, if you want to use. What is the complication of this lepatinib? Cardiac. What is foot-mouth syndrome? So now what do you want to do for this patient? Your patient. In your case, what you have done or what you want to do?
Proceed, man.
After discussing in a
மைக்க பக்கத்துல வச்சிட்டு
after
பேசு.
discussing in a multidisciplinary team, after discussing with the patients, I will opt for breast conservation therapies.
Breast conservation. What is the contraindication for breast conservative surgery?
First and second trimester of pregnancy.
First and
Second trimester pregnancy.
why?
We can't expose her to radiation.
Radiation.
Radiation we can't expose her.
No, second trimester is up to 6 months. No, another 3 months she will deliver.
Within 4 to 6 weeks we have to give radiation.
Within
4 to 6 weeks we have to give radiation.
yeah, then within 3 months means it is only 12 months, 12 weeks. Can you do MRI? How will you diagnose a carcinoma breast in a pregnancy? What method you will diagnose carcinoma?
Same triple assessment, clinical,
Clinical, that
radiology.
what radiological investigation you use?
MRI,
MRI.
USG.
USG.
MRI should not be used in a pregnancy. MRI will produce, because there is a lot of cellularity, increase in cellularity, intensity will be more, the vascularity is more, that will always give a false positive result. Can you take a CT? CT can be taken very much more safer than MRI. Gadolinium, will it transfer placenta cross? So you can't use a gadolinium. You can use a. So ultrasound is, you can make it out. Can you use a mammogram?
Yes, sir. We can do.
Okay, so you are thinking in terms of what are the other contraindications for doing a breast conservative surgery?
Multifocal and multicentric disease. Diffuse
Keep the mic closer.
diffuse microcalcification.
Sometimes when we say that you need to take care. Huh?
Diffuse microcalcifications in a mammogram.
Diffuse microcalcification is one focal microcalcification.
We can do these.
So this you are going to decide before neoadjuvant. Are you going to give a neoadjuvant therapy or not for this? This is early breast carcinoma.
Early breast cancer.
Okay. Suppose it is a diffuse microcalcification. Can you give a neoadjuvant therapy?
Triple neck.
What do you mean by diffuse microcalcification?
There will be extensive in situ component.
It is a
DCIS.
See, extended DCA is different. Diffuse microcalcification is different.
Multicentric.
So you are giving a neoadjuvant therapy. How will you assess in the postoperative period? I mean, whether you are fit for the BCA or not?
Response evaluation in solid tumors. We have to follow the RECIST criteria.
You will not speak on the mic at all, no?
Sorry, sir. We have to do clinical and radiological assessment, sir.
How will you assess it clinically? How will you assess radiologically?
Clinically,
Clinical breast.
clinical breast examinations.
Hmm?
Clinical breast examinations.
Hmm.
If there is a
Radiological
complete or
MRIs.
partial response, if there is a stable or progressive disease, we have to classify, sir. But radiologically, we have to do MRI.
Hmm. So how will you MRI or the how will you assess on MRI?
There will be reduction size of.
There will be reduction size. So what?
Concentric.
How the reduction is taking place? Is it a concentric reduction or is it eccentric reduction? If it is a concentric reduction, you can go by the new size. The size of the tumor can be considered as what is the new after the concentric reduction. Then you can decide on that. If it is an eccentric, the original size of the tumor should be considered before you are planning for the breast conservative surgery. If that original tumor was 6 centimeter and you are going a staple or eccentric concentric reduction, you can't do a breast conservative surgery because the original size has to be taken into consideration. But if you are seeing a concentric response, then you can always take that response size. That size can be taken and you can go for a breast conservative surgery. So you are planning for a breast conservative surgery. What are the immediate important steps in the breast conservative surgery? How will you do breast conservative surgery? Describe the breast conservative surgery.
Can be either volume displacement or replacement method.
That is a reconstructive surgery.
Wide local
Wide
excision
local
with a 1
excision.
centimeter macroscopic margins.
So this is this centimeter. I make a wide incision and make a excision. So normally when a lumpectomy, when you say wide excision, we take a skin along with that and do that. What are the peculiar steps? It is mandatory steps in the breast conservative surgeries.
Sentinel lymph node.
You know the case you are presently discussing, no? Why you are not studied?
Node negative tumors are. We'll do a sentinel lymph node biopsy.
We are not going to sentinel lymph node. Idhila mattu kekranga.
Breast conservative surgery is posted for breast conservative surgery. How will you do? So you are not. Anybody from the audience doing breast conservative surgery? How do you?
So that's what is the plane?
Here there is skin fixity.
Okay.
So we can't spare the skin.
So you need to remove the skin. Okay.
Nipple sparing can be done.
Nipple sparing can't be done.
Can be done. It is 2 centimeter away from the nipple area.
What is the deepest limit? How deep can you go?
To pectoral fascia.
So what's the thing is, the tumor will be irregular shape. Okay, you cannot just stick onto a uniform circular incision. It's not possible. Okay, so you palpate, give 1 centimeter clearance at all levels. So suppose if it is spherical, then you can give a spherical resection, but the tumor will be mostly irregular. So you palpate at a particular point, give 1 centimeter clearance. Okay, so depending on the depth of the tumor, pectoralis fascia can be removed or may not be removed. So if the lesion is close to the skin, you remove the skin. Okay, so these are the basic things. And after you remove the lump, you mark the tumor bed. Why do you want to mark?
Orientation.
Huh?
Orientation. If
You mark the specimen or mark the tumor bed?
Both
You don't.
We are talking about specimen. That is talking about the tumor bed.
tumor bed.
Why do you mark the tumor bed?
If a margin is
So
positive,
most of the recurrences are common in the tumor bed. Okay, so the radiation oncologist should know or tumor bed boost.
You have done a breast conservative, it comes as a margin positive, what you will do next?
cavity shape of 1 centimeter.
Again it is going for surgery.
surgery.
So that also which part where you need to know.
So ideally you should have a frozen section by your side. So when you give the specimen, you should wait for the pathologist to comment on your margin positivity. So what is the basic margin you would expect? How much margin will you give?
No ink on. Macroscopically 1 centimeter.
Microscopically 1 centimeter. Microscopically?
No ink on.
No ink on margin.
No?
Ink on tumors.
No? Ink on tumor. Okay. That is the margin you. Okay. So you mark the tumor bed. And suppose here in this case it is axillary node negative. So you can go for a sentinel lymph node biopsy. So you give tumor infiltration on all 4 quadrants around the tumor, wait for 20 minutes and then do a sentinel lymph node biopsy. What is the minimum number of sentinel nodes you will remove?
Minimum 4 nodes should be.
Minimum 3 nodes. Okay, at least you should remove minimum 3 nodes. Okay, so if the sentinel nodes are negative, then what will you do?
Give adjunct radiotherapy.
If the nodes are negative, close it and come. Don't proceed with axillary lymph node dissection. If they are positive, then go for a complete axillary dissection of level 1 and level 2. Okay. So next comes your oncoplasty. How you are going to fill the tumor bed with tissue. What are the 3 steps in oncoplasty or 3 stages in oncoplasty? Level 1, level 2, level 3.
You said something, volume expander or something.
11 is volume displacement. So if the raw area is less than 20% of the tissue, we can replace it with the breast tissue itself. Sir. With the breast tissue itself.
The voice put up on the
If it is more than 20%, we have to go for replacement with tissue flaps.
Can you give some examples?
Latissimus dorsi.
That is level 3. What is level 2?
Superior pedicle.
Yes. So level 2 is glandular mobilization. Okay. So what comes under level 3? Flaps. Okay. Intercostal, anterior lateral intercostal perforator flaps. So you should have some idea when you talk about breast conservation. You should have an idea about oncoplasty also. Okay. So after you are done with lumpectomy and asentinel lymph node biopsy, now what are you going to do?
Your surgery is over, BCS is over. Then
Adjuvant radiotherapy.
Radiotherapy to where?
Tumor bed breast.
See what routinely practically is being done is when you plan for brachytherapy alone, okay, when you plan for brachytherapy, suppose if you are inserting any needles, in that condition you give radiation after surgery. In all other conditions after surgery you proceed with adjuvant chemotherapy. Okay, you treat the systemic disease and then come to the breast for irradiation. Okay. So if you are not planning for brachytherapy, go for adjuvant therapy after your surgery. Okay, your adjuvant depends on the hormonal status. Okay, what is molecular classification of breast cancer? What is luminal A, B?
ER and PR positive with
Only two, ERPR.
first is luminal HER2 neo and K67.
So
Proliferative.
tell me,
luminal A, what is luminal B?
Luminal A, ERPR will be positive.
in both, luminal A also ERPR positive, luminal B also ERPR positive. Now tell what is specific for
Luminal A, ERPR and HER2 neo will be positive.
What will be positive?
high positive, low positive, which is
What about K67?
Low.
ERPR will be high. So when you will say high,
ER more than 10 symptoms.
10 is normal,
30 minutes symptoms.
So ERPR high and HER2, I mean K67 low. So luminal B,
K67 will be high proliferative.
this is not good. Exam going student coming to the this and case is also given to you much earlier. You're not spending time and
For any case, don't, if even it is early breast carcinoma, you should read, your mind should be prepared that to answer the questions regarding neoadjuvant, locally advanced breast cancer. Not necessarily if your case is early breast cancer, we'll proceed with MRM, only that steps. As a PG, any variety of case scenarios can be given regarding the cancer breast. We cannot ask anything from the CA stomach if your case is CA breast, but we can ask anything for the CA breast, starting from the etiology, neoadjuvant chemotherapy, molecular staging, oncocyte typing, and HER2 positive, what is the metastatic cancer, anything can be asked. So don't mind that if it is early breast, I will be asked about the MRM. So it is not like that for PG. For cancer breast, you have to, from the bottom to the top, you should know everything. Even the latest, what is the NCCN guidelines, latest guidelines, what has been included, what is not included, what is the molecular classification that is newly added. Everything should be, you should read it.
discussion can be on that. So all how will you say this is when you take a mammogram? Can you say it is a secondary breast? Mass can become the secondary coming into the breast. What will be the changes will be there?
They can ask anything.
Margin. So what will be there? So all even pure anatomy. What is the blood supply to the breast?
Internal mammary artery.
How?
Second, third, and fourth perforators. Perforating.
Fourth,
2, 3, and 4 perforators.
the rest of the breast?
From the posterior intercostal artery, lateral branches of posterior intercostal artery and axillary arteries.
So internal mammary artery supplies only the first 3 intercostal space. What is superior epigastric artery? What is musculochronic artery?
Internal branches.
You have to read a lot, starting from the anatomy, investigation, everything. What is the each and every part of the investigation? What are the advantages, disadvantages? What is the indication for MRI? How opposite? You can ask how your opposite breast can be affected, whether it is a synchronous or metachronous lesion, or it is a primary or a secondary. How will you diagnose? Because CA breast is a common case you will come across when you practice as a general surgeon. You cannot say that I am not a surgical oncologist, I don't know anything.
So now we are coming to almost an end. We need any input from your PGs there. Anything more you would have included in case discussion? Any opinion? So is it useful one? I must thank because most of you sat continuously. It's a little difficult to sit continuously and listen. But we didn't want to waste time. That is why we restricted and most of the time we wanted to use. But I must thank all the professors because they spend quite a lot of time. Because most of the time when we go for this, we have only 1 hour session, we will run away. But all the professors had to spend quite a lot of time with you. And it is only because of their support that we are able to do that. So I must thank once again all the professors from the different colleges who has permitted you to come. The time is short. Now you need to, there is no excuse because now knowingly, unknowingly, the levels of examination is also going to be little high because all the examiners are looking into the various classes. We previously only 1 college or 2 colleges will be conducting. Now almost all the medical colleges are having a CME program, so it always increase the level of examination standards also. So we request you all to study, but don't worry too much because if you have already worked in the ward and seen the case with the sincere efforts, definitely you will be happily can go through that. But only when you start confusing and straight basics when you are going to query, it will be a problem and nobody can help you at that moment. In the advanced level of discussions, it is only going to give an additional marks when you have further classification, further staging, all that. Never come to the examination and argue because opinion differs even among examiners. Opinion among general surgeons and onco-surgeons. Opinion differs from different. So you can present your views, and if possible, even if you can want to quote something, you can quote. But nothing wrong in that. The positive examiners will not find fault with you just because you are quoting something, because that is your understanding. But you must always try to see that looking at the case in a comprehensive style. Don't come with a one diagnosis and go and approach. So in an open mind, approach the case and present. Confidently present. Own the case and present. Don't say that patient is somebody that. You must always start with is my patient and present. Diagnose also says my patient is having carcinoma stomach. That ownership of the patient should be there when you are presenting, like advocates argue in the court. It is like an argument you are making in the court to make sure that points of view. And we don't just punish you because you say something a different view. And if you can explain that and why you are thinking on that, and definitely it is been accepted. And controversial points will never will be points to decide. So wish you all the best. So read well and hope we will all see you as good surgeons in the near future. Okay. Amala is happily clapping. Very confident.
No, always you say what it has been practiced routinely in your college. You can substantiate that it has been practiced routinely in our college, but these are the other methods available also. Now, உங்க காலேஜ்ல என்ன practice பண்றாங்களோ you will feel it boldly. இதுதான் நடந்தது இதுன்றது if your experience you can talk it.
அது பார்க்கணும், வார்டுக்கு போகணும், மேமோகிராம் பண்ணுற இடத்துல போய் பார்க்கணும், அல்ட்ராசவுண்ட் பண்ணுற இடத்துல போகணும். Don't this habit you must make.
நீங்க பேசுறத வச்சு தெரிஞ்சுக்கணும் how frequently you have worked in the ward, how frequently you have seen the cases.
Especially the ward rounds also has a lot of marks. The ward rounds will be mainly on a practical points, what fluid you are going to use, what type of management you are going to see. So that also protocol level of management, that also you should be important, because it is very difficult to fail in MS exam. Remember, because we have a lot of scopes to make it up. Short case, long case, and olden days it is a one failure will make you a fail, but it is not so now. You only unless you comprehensively failed in multiple area, and definitely one area can make you up. So it is a short case or a long case, your case. So even if you fumble at one point, never get discouraged, never get things. Forget it. The next moment is yours. Change, adapt to the next moment, and go on approach. Because if you do extremely well in a long case and ward rounds, I think invariably you will make it up the marks. Because it is individual. It is not a comprehensive assessment. It is only individually we are going to assess that. So I wish and I hope, because as a examiners we have seen, it is we never come for failing anybody. 100% no, but at the same time we are not too lenient also. If you just because we that is for, because tomorrow you are going to operate on us. You are the surgeons if it is going to operate on us. So we that quality we will definitely do that. So all the best. Anything from Tuticorin and long distance people came? Anything? Okay. Thank you. But you need to. Among all the postgraduate scene, I am a little disappointed with your presentation. Probably you have not had enough time to see the case or that. So,
தப்புனால யாரும் ஃபெயில் ஆயிட மாட்டாங்க. You should recap with another one. டக்குன்னு அடுத்தது மாறி போயிட்டே இருக்கும். As a surgeon you cannot fail இல்ல. போறீங்க வேற ஏதாவது இருக்குனா you cannot change இல்ல.
அயோட்டாவை கட் பண்ணா கூட இது பண்ண கூடாது. வேற ஏதாவது பண்ண முடியுமான்னு பார்க்கணுமே தவிர don't get funk. All the best.
Thank you everyone.